Hey guys, welcome to my abdominal pain video. So today we're going to be going through the right upper quadrant of the abdomen and seeing what's going on in terms of things that can be causing pain in that region. So the right upper quadrant is also known as the right hypochondriac region. We have a couple different organ systems going on here, so the liver, the gallbladder, the head of the pancreas, as well as the right hepatic flexure of the colon. And we're going to be going organ by organ and seeing what could go wrong that would cause pain in this region. So let's start off with the gallbladder. Here we have a basic anatomical picture of the biliary system connected to the gallbladder, our common hepatic duct coming down, our cystic duct connecting our gallbladder to our common hepatic system, and now we have our common bile duct where both the hepatic and the cystic bile is going down into the ampulla of Vater, and eventually it will go down here into the duodenum. Okay, and also we have our pancreatic duct, which is connected to our pancreas, also contributing its enzymes and other digestive products to go into the duodenum. So let's focus on the cystic component of this, also known as the bile duct component. And let's start with cholelithiasis. And what that basically means is we have gall stones. Now, these can be cholesterol stones, biliary stones, and they can have multiple different root causes. If for a cholesterol stone, for example, you could have hypertriglyceridemia, and for biliary stones, some sort of process that's lysing red blood cells, excreting extra bilirubin, causing it to build up. And also parasites like Clonorchis sinensis can cause biliary stones. When we have cholelithiasis, these stones usually are pretty benign, but they can cause pain. So let's say you have a large meal and the duodenum detects the meal, releases CCK. CCK causes the smooth muscle of the gallbladder to contract, and it contracts onto these sharp stones, causing pain. So this is usually pain after meals, and it usually lasts less than 6 hours. On laboratory examination, there's not going to be anything really elevated. So the liver labs and the inflammatory markers are not going to be elevated because these stones are causing just transient pain and transient inflammation. Now, if we do a diagnostic imaging, we'll see on right upper quadrant ultrasound an acoustic shadow that is caused by these stones, and that's going to be our main diagnostic marker. So you just need an ultrasound to diagnose this. In terms of treatment, we have supportive care, analgesics for pain control, and eventually an elective cholecystectomy if this is causing recurrent issues for the patient. Next, let's move on to cholelithiasis. So that's a complication if one of these stones manages to pass through the cystic duct into the common bile duct. Okay, so that's a common bile duct issue. Now our stone is in here and it's causing all sorts of problems. By obstructing the common bile duct, not only can bile not flow from the gallbladder, it can't flow from the liver either, right? So we're going to have liver complications. What we're going to see here is that the patient's going to have right upper quadrant pain, and it's going to last usually longer than 6 hours. This is no longer a transient issue. It's pretty consistent. Okay, and if we're doing laboratory tests, we now see the liver got involved. So we have elevated AST, ALT, alk-phos, and total bilirubin. Now, if we're going to diagnose this, we'd want to do a right upper quadrant ultrasound. And what we're going to see is all these ducts that are filled with bile are now dilated. And we can also do an MRCP or ERCP. Now, what's the difference between those? So MRCP stands for magnetic resonance cholangiopancreatography, and that's a non-invasive method. So it's like an MRI for this system. And what you're going to see is what the ultrasound already basically showed you, dilated ducts. And ERCP is endoscopic retrograde cholangiopancreatography. So we have an endoscope sent down and into this biliary system, and that endoscope can actually be used not only to diagnose this condition, so you'll see the dilated ducts, but also you'll be able to remove the stones. So the probe that we sent down into the system can now remove and destroy the stone, effectively treating your condition at the same time. And of course, we're going to want pain management and supportive care for them as well. Next, we have our more severe condition called cholangitis. Now, cholangitis is a complication of cholelithiasis. So our stone is stuck, and if it's stuck for long enough, we're going to have bacteria from the small intestine, from the duodenum. It's going to travel up the biliary system and eventually into the hepatic biliary system. Now when that happens, a whole lot of inflammation is going on, okay? So we're going to have all these bacteria causing white blood cell count elevation, causing elevated CRP, and the patient, how they're going to feel that is through two ways, so through Charcot's triad or Raynaud's pentad. Now, the triad has three classic features of right upper quadrant pain, fever from the infection obviously, and jaundice from the biliary obstruction, and we're going to have Raynaud's pentad in more severe cases, where that is also associated with hypotension from the infection and altered mental status, because now we're going septic essentially. Alright, so on labs, we're going to see our elevated liver labs as we saw before, and on top of that, we're going to get an elevated white blood cell count and CRP. And in terms of diagnosing this, we have our ultrasound, which is going to show our dilated ducts, similar to cholelithiasis, and we can also do an MRCP if we really want to be sure to confirm. Now, the MRCP is non-invasive, remember, so we're not doing an ERCP because we don't want to irritate this system anymore. It's already inflamed, and we don't want to introduce more bacteria into the biliary system, okay? In terms of treatment, we have our supportive care, our pain management as before, but now we have IV antibiotics because we want to get rid of those bacteria and calm this down. So eventually we can do the ERCP if we still need to remove the stone. And we can also do urgent biliary decompression, also endoscopically, if we need to decompress the system, if too much bile is building up and causing a lot of inflammation, irritation. Okay. After that, the patient will also most likely get a cholecystectomy in order to remove the source of the stone and prevent this from happening in the future. And moving on to our last diagnosis here we have to consider is cholecystitis. Now this is a relatively simpler diagnosis because it's just inflammation of the gallbladder wall. Now this can be either happen through stones irritating the wall or through biliary sludge causing wall irritation. And what we're going to have is right upper quadrant pain, fever, and a positive Murphy's sign. So these three things. Now that's different from Charcot's triad, remember. So that's right upper quadrant pain, fever, and jaundice. Here we have a positive Murphy's. So the Murphy's is when you ask the patient to lie down and then you press on their right upper quadrant as they inspire, you're going to see them stop breathing because of the pain. So you've pushed on an inflamed region, which is halting their breathing. And they're also going to complain that, ow, that hurts, obviously. In terms of labs, we'll only see elevated white blood count and elevated CRP. Why? Because this is an isolated condition to the gallbladder wall. The bile is still flowing perfectly normally, all right? So we're not going to see anything elevated with the liver in terms of that. And then on imaging, ultrasound will show gallbladder wall thickening. We can also do a HIDA scan to confirm, which will show the same thing. And in terms of treating this, we have supportive care, IV antibiotics, which will help quell any kind of infection that might be causing this kind of gallbladder inflammation, and cholecystectomy depending on when the inflammation gets under control and the procedure can be done so it can be avoided in the future, as well as the risk of this being associated with the gallbladder malignancy.